Hello everyone, my name is Dr. Parth Patel. I am an internal medicine resident at Henry Ford Allegiance Health in Jackson, Michigan. We present a case of thin basement membrane disease coexisting with minimal change disease. Thin basement membrane disease is characterized by diffuse thinning of the glomerular basement membrane and minimal proteinuria. A 20-year-old female presented with facial and peripheral edema progressing to anosarca and a weight gain of 10 pounds within a few days. She had 3 grams of proteinuria, microscopic hematuria, and normal serum creatinine. Her only medication was ibuprofen for pain. With nephrotic range proteinuria, minimal change disease was a primary differential. However, a biopsy was not done at that time. With persistent concern for steroid-responsive and perhaps NSAID-induced MCD, the patient was advised to abstain from ibuprofen and was treated with prednisone for a total of 12 weeks, including a taper. Immunological testing, including anti-PLA2R antibody, was negative. She also denied a family history of Alport disease. Her proteinuria and edema resolved with glucocorticoids and cessation of ibuprofen. 3 months later, the patient had recurrent proteinuria more than 2 grams with bilateral peripheral edema. The patient underwent a repeat biopsy which showed diffuse glomerular capillary fluid process effacement consistent with MCD and a diffusely thin basement membrane consistent with thin basement membrane disease. The patient was then initiated on a 16-week course of prednisone with a slow taper over 6 months. Thin basement membrane disease is considered a common disorder. Although it is seen in 5 to 9% of biopsies, it is clinically diagnosed in less than 1% of the population. It is often hereditary and not transmitted in a dominant fashion. TBMD is associated with defects in the genes that encode for type 4 collagen. Family history of microscopic hematuria is usually seen in 30 to 50% of cases. The characteristic manifestations of TBMD is persistent or intermittent asymptomatic microscopic hematuria. It is often found incidentally. Occasionally, patients can have gross hematuria and flank pain. Red blood cells enter the Bowman space in TBMD through transient ruptures in the glomerular capillary wall. Biopsy is not required usually for diagnosis. The treatments are ACE inhibitors or ARBs. There is a good long-term prognosis. The electron microscope images of TBMD in our patient are seen here below. The center of the slide shows the thin basement membrane. Minimal change disease is a major cause of nephrotic syndrome in children, but less common in adults. It is the cause of 10 to 15% of all cases of adult nephrotic syndrome. Glomerular permeability is increased in MCD. The leaky glomerular basement membrane causes proteinuria. Proteinuria causes hyperproteinemia due to the loss of proteins in the urine. Hyperproteinemia results in decreased oncotic pressure, which causes edema. The histological finding is diffuse effacement of the podocyte fluid processes on electron microscopy. This is characterized by sudden onset of the signs and symptoms of the nephrotic syndrome. Bone marrow biopsy is required in adults to rule out other pathology. Our patient represents a unique case of TBMD with heavy proteinuria due to MCD. There have only been 3 such cases reported so far. Persistent hematuria in the absence of other comorbidities should prompt a differential, including TBMD. The presence of concurrent nephrotic range proteinuria should raise concern for other diseases, including MCD. Patients should undergo a renal biopsy before treatment with glucocorticoids, since MCD is a steroid-responsive disease and can be missed after a short course of steroids. I thank Dr. Bhatia for her assistance on this case report and Dr. Luthra for this opportunity and guidance.